Thanks.
Thank you.
Thank you. I was outside yucking it up with Jose. But one of the limitations of below-the-knee revascularization is the arteries in patients themselves. And they're often very long, complex calcified lesions. There's often multi-level disease or associated disease apart from just the below-the-knee occlusions. Because of our technologies, as high as restenosis rates. And then limb salvage is poorly correlated to primary patency, mostly related to secondary patency. And the literature is replete with small series and case studies with limited level 1 evidence. And as I pointed out a second ago, the types of lesions below the knee are very different than even the lesion we saw earlier today in the live case. Above the knee, calcification is less frequent than below the knee. The presence of CTOs is a little bit higher. So these two factors really account for diminishing primary patency rates and also limit some of the technologies that we can use. So going back to the evidence supporting angioplasty alone for below the knee vessels, technical success is actually quite high. We as operators can get these vessels open with most of the failures related to task D lesions. As technology has advanced, even these task D lesions, as you can see from the case today in the SFA, can be treated with pretty good success. The problem is the primary patency rates and the rates of limb salvage. And amputation rates for patients who aren't getting distal pedal bypasses or with these complex lesions are obviously very high. So the initial experiences with drug-coated balloons below the knee will go through 2 to 3 of the first studies. Here's a single center registry in the Leipzig registry of 80+% of CLI patients, mostly diabetics, with long lesions and a high prevalence of CTOs. You see that the drug-coated balloon in yellow has lower restenosis rates and lower TLR rates, really dramatic differences. These were very impressive outcomes with regard to the target lesion. Similarly, in the DEBATE BTK study, 130 patients, all with CLI, all with diabetes, long lesions, lots of CTOs. The drug-coated balloon performed very well. I was going to say admirably with no pun intended, but 12-month restenosis rates very high with in gray with PTA and significant but much lower rates with the drug-coated balloon. Now, one of the differences between the two studies related to the clinical endpoints. So you see in the Leipzig registry, limb salvage rates were quite high, deaths were not statistically different, wound healing no different. And that's because there was less of a standardized post-procedure management regimen. And in comparison with DEBATE BTK, major amputation rates not significantly different, but wound healing much higher or advantage drug-coated balloons. And that's because there was a standardized follow-up in part. A very comprehensive follow-up for the first 2 months, and then once a week for the third month. Office visits obviously were part of the protocol. So to summarize now the 3 major-ish studies, Leipzig, DEBATE, and DEBELLUM, you see that there's some variance in the severity of illness with the patients, with death rates varying. Limb salvage rates are not reported in all of the studies. Amputation rates also varied, and wound healing rates in active treatment versus PTA alone show significant differences between studies. So to summarize, the early evidence showed high promise related to reductions in restenosis and reintervention rates. There was significantly higher restenosis rates in these studies versus DES, which I didn't show you, with extremely long lesion rates, lesion lengths, and then no difference in primary patency with the other drug-eluting balloon at 6 months, but a hint towards efficacy. We'll see more on that when we look at the randomized trials. So what about the largest randomized trial, in this case with the Medtronic balloon coated with paclitaxel? This was about 358 patients, multi-center trial, independent angiographic core lab and wound core lab, external monitoring, and no difference, a failure to meet the primary efficacy endpoint of 12-month late lumen loss or clinically driven TLR. And primary safety endpoint, death, major amputation, met a non-inferiority boundary, but not superiority. So looking in the context of the rest of the CLI literature, in an effort to explain the difference between the single center experience and the randomized multi-center experience was difference in overall event rates. So in part, maybe the trial was not powered because the absolute difference in event rates was much smaller. There was a 2-to-1 randomization, and maybe the variance in the outcome amongst the control group was the reason why no difference could be found. But you see overall for both the PTA and the active treatment groups, the event rates are much lower. And this was alluded to during the live case where it was mentioned that our balloon angioplasty technique has changed over time, and maybe this translates into lower restenosis rates regardless of what balloon is used. There was also a small signal related to the rates of major amputation with drug-eluting balloons, whether this was statistically a fluke or whether a real phenomenon. Nonetheless, there was a numerical difference of 8.8% versus 3.6%. And again, in context, though, overall amputation rates are much higher historically than were seen in either arm of this trial, with very low amputation rates in the PTA arm. And this may relate to the fact that the control group had much better outcomes than one would have anticipated when planning the trial. In addition, as you saw in the case when we looked at the SFA earlier today, there were differences in how the artery was treated depending on what treatment was assigned to the patient. So although there were differences in the patient level characteristics, there was more predilation in patients with receiving drug-coated balloons, obviously. The lesion lengths were somewhat different, wound depths were different, et cetera. And in addition, there were differences in inflation times, procedural complications, et cetera. One would have thought that this would have been corrected for by randomization, but obviously there were numerous and probably substantive confounding factors. So looking at now the Biotronic balloon that I mentioned earlier, you see in 72 patients, again, less than enthusiastic results, looking at 12-month loss, TLR, and amputation rates in using this balloon. So to summarize the 6 and 12-month results with that trial, as well as the Inferion balloon coated, you see differences in freedom from TLR in active treatment and also across the time of follow-up. But in general, no differences in clinical endpoints and no significant differences in TLR. So why the difference between substantial differences in single-center trials versus multi-center trials? And we've seen this time and again in interventional cardiology as well as in the periphery. A number of disease states and interventions can be mentioned, not only renal denervation, but thrombectomy, where we see very impressive outcomes when it comes to single-center trials that are not necessarily replicated in multi-center trials. And what about the differences between below the knee and in SFA trials? Well, as I mentioned, there's a higher disease burden in CLI patients, more distal, smaller vessels. As Doug alluded to earlier, some of the kinetics of drug delivery may be different. Different trial designs with more encompassing patients enrolled in BTK trial, CLI trials than in SFA trials. And then obviously there are differences in the balloons and maybe how well they work. So in conclusion, the randomized trials have failed to demonstrate superior treatment effect of these balloons. Procedural safety and feasibility is confirmed. We have to investigate the signal detected in major amputation rates. There are ongoing trials of these BTK balloon technologies. This is one. Recently reported is the ongoing Lutonix DCB BTK registry, which plans to enroll 500 patients just 6 weeks ago. Initial descriptions of the patients were reported, but you can see these are very complex patients with lots of comorbidities and symptoms. Anterior tibial, 50%, 123 millimeter target lesion length, lots of calcification, and initially, at least at 6 months, relatively encouraging results. And just a second about calcium, we talked about it a lot in the SFA. It definitely has an impact in below the knee outcomes. And so looking at trying to facilitate drug delivery by utilization of atherectomy is the subject of the optimized BTK study. I'll tell you that the primary endpoints may be relatively unsatisfying in these small number of 50 patients, but nonetheless, this proof of concept may be helpful. So the bottom line is that in comparison with uncoated balloons, infrapopliteal vessels with DCBs have similar clinical outcomes, favorable angiographic efficacy at 1 year, but we need further studies. So I believe, my opinion is that it's still not the standard of care for below-the-knee intervention. Small-scale series show promise, but in the meantime, the technology needs to evolve. There may be a role for combination therapy, and we need to also have multilateral approach with surveillance, wound care, so that we're not just focused on the initial procedure. And with that, thank you very much.